Good morning, everyone, and welcome back to COPRHCon Day 2. I'm very excited this morning to introduce our Day 2 keynote speaker, Dr. David Vock. Dr. Vock is an associate professor in the Division of Biostatistics in the School of Public Health at the University of Minnesota. He's the McKnight Presidential Fellow in the Division of Biostatistics and an expert in methods to mine electronic health data, assess the causal effect of time-varying interventions, and to develop personalized treatment strategies. He collaborates extensively with outcomes researchers in a variety of areas, including solid organ transplant, smoking cessation, adolescent depression, and obesity. Dr. Vock has recorded his presentation, which we'll play in a moment, and he'll be available on chat, so please engage with him throughout the talk this morning. With that, we'll start the presentation.
I'd like to thank the organizers for the opportunity to talk today about the benefits and challenges of leveraging existing and secondary data for pragmatic research. This is some of my perspective as a biostatistician at the University of Minnesota who frequently engages and collaborates with pragmatic researchers. As this is a pre-recorded talk, I would encourage you to please reach out during this session. I'm available to answer questions or comments using the chat box here in Zoom, or you can tweet at me. My handle is @DocVock. Now, of course, it should be noted that using existing or secondary data in and of itself is not novel. There are many researchers, including health services researchers, health economists, and others who make their entire careers out of using only existing or secondary data. Conversely, there are many health researchers who use only prospective data, either in traditional randomized controlled trials or in epidemiologic cohort studies. The question before us today is there some middle ground in these two different research approaches? In particular, what can practitioners of prospective data collection leverage from existing and secondary data? So when I'm talking about sources of existing or secondary data, some of them that I've used in my statistical practice include medical records, which come from providers of medical care, insurance claim data, which come from payers of medical care, as well as registries or completed studies. These often come from government agencies and could include things like state death certificates, Social Security Death Master File, or other government or private sponsored registries. Of course, it should be noted that there are many other sources of existing and secondary data that could be used in pragmatic research. Now, existing and secondary data have many strengths which have been noted in the literature. In particular, these data are often contemporaneous, and they capture information on those who seek care. And while that's not a perfect representation of a population of interest, it is often quite diverse and large nonetheless. Existing and secondary data often contain information that's available and relevant to clinicians and patients, in particular because these data were collected for purposes other than research itself. And lastly, because these data already exist, they are often quite inexpensive to use for another research project. Now, of course, existing and secondary data come with many limitations. And this balance between benefits and strengths and weaknesses and challenges is what forms the basis of this talk. And in particular, I want to make 5 key points of this talk. We'll discuss them now, and I'll reiterate these throughout the talk. In particular, I want to emphasize that existing and secondary data can and should be used at many points in the life cycle of pragmatic research, not just exclusively as a substitute for data collection. Of course, any data source that comes with limitations, it should be interrogated for not only what it does include, but also what it does not capture, in particular, what it does not systematically capture. Now, using existing and secondary data often requires a solid data integration and security plan. Now, these weaknesses, limitations, or challenges of existing and secondary data can and should be ameliorated in the design and analysis phase. And lastly, I want to emphasize that many of the perceived weaknesses of existing and secondary data can and should be reframed as strengths for pragmatic research. And I want to make these points in the context of different case studies. In this talk today, we'll focus on a case study involving an ongoing study of assessing the long-term health consequences of living kidney donation. Due to time constraints, other case studies are going to be presented as extra slides that are available for download from the conference website. Now, first, a little bit of background on living kidney donation. Kidney transplant is considered the definitive treatment for patients with end-stage kidney disease. And outcomes with a living donor are markedly better than with a deceased donor. This is due to a variety of reasons, including better immunologic matching with a living donor as compared to a deceased donor, as well as a kidney that is often better functioning that comes from a living donor as opposed to a deceased donor. Additionally, living donor recipients can often identify their donor soon after starting dialysis, or in some cases, even before starting dialysis, and thus require a shorter amount of time on dialysis until they receive a transplant, unlike deceased donor recipients who often have to wait for a prolonged period of time on a waiting list. But it's important to acknowledge that in spite of the fact that recipients do better with a living donor, living kidney donation poses risks. These include perioperative mortality, which is often quoted at 3 per 10,000, as well as major perioperative complications, which occur in about 3 to 6% of donors. But the focus on risk is not just with perioperative complications. Indeed, in the last decade, there's been an increased focus on long-term outcomes of living kidney donation. And in general, while donors initially lose half of their kidney function when one of their kidneys is removed, they do regain some function in their single remaining kidney and can expect to have about 70% of pre-donation function within 1 year of donation. Of course, the natural question is does giving up approximately 30% of kidney function have implications for long-term health? And in a seminal paper that was published in JAMA in 2014, Mazzali and colleagues showed that living kidney donors had an increased risk of end-stage renal disease over the first 15 years post-donation compared to similarly matched healthy controls. Indeed, the risk of end-stage renal disease increased from approximately 5 per 10,000 at 15 years post-donation to just over 30 per 10,000. So while the absolute difference in the attributable risk of living kidney donation on end-stage renal disease was small, the relative risk was relatively dramatic. This was based on data from the United States. However, Mohn and colleagues found similar results using a Norwegian cohort. And indeed, this research actually showed that living kidney donation had an adverse effect on all-cause mortality as well as incidence of cardiovascular disease. Importantly, these two studies focused on outcomes that were within 15 and 25 years post-donation. However, our group at the University of Minnesota has shown that the risk of end-stage renal disease increases dramatically from 15 years post-donation all the way to 40 years post-donation. So while much of the research on the attributable risk of living donation used data early on after donation within 1 or 2 decades post-donation, much of the risk occurs 3 and 4 decades after donation. And so a key unmet or unresolved question is, what are the long-term risks, for example, 20 or more years after donation, of kidney donation on the development of end-stage kidney disease and other intermediate endpoints such as chronic kidney disease or hypertension, and secondary outcomes like all-cause mortality, cardiovascular disease, among others. This is a question that necessitates the use of existing and secondary data. National registries of living kidney donors are relatively recent developments. There's no significant registries containing potential matched healthy controls, or even registries that have long-term follow-up on generally healthy people that last 2 or 3 or 4 decades. And so the first point that I want to come back to is that existing and secondary data can and should be used at many points in the life cycle of pragmatic research. And we'll see that in this study here. Again, as I mentioned previously, a lot of times existing and secondary data is viewed as a way of augmenting or replacing data collection within the context of a pragmatic study. But there's so many other phases of any research study where existing and secondary data can come into play. It can come into play in the design and planning phase of a trial, which is what we'll see very shortly here. But it can also come into play in the analysis and dissemination phase. For example, after a randomized controlled trial, we might use existing data to help calibrate or generalize the findings of an RCT to our population of interest. And so a natural question becomes, how can we use existing and secondary data in each of these 3 phases of study design and implementation? And in particular, what changes to these phases must be done in order to accommodate the use of existing and secondary data? And I want to emphasize that this talk in no way can capture all the different ways that existing and secondary data can be used across these 3 phases of research. But many talks at this conference are going to address this particular question. So yesterday, there were many talks that dealt with designing and planning, as well as analysis and dissemination when using existing and secondary data. There'll be additional talks today that focus quite heavily on study execution and data collection, particularly when we're using existing and secondary data, and a plenary address on the final day of the conference on Wednesday as well. And so all of these will provide much more comprehensive and interesting findings on using existing and secondary data in pragmatic research. So a little bit of background on the data that we do have in the context of our living donor study. So the University of Minnesota has been doing living donor kidney transplantation for upwards of 60 years. And overall, more than 4,000 living kidney donors have undergone donation at the University of Minnesota. The University of Minnesota has a robust data collection on outcomes of living kidney donors. So since 2000, donors are contacted and asked to complete surveys of their health history every 3 years. And although this formal data collection has started within the last 20 years, the data collection involves donors that go back all the way from to the inception of the program. Now, this database, which I'll refer to as the University of Minnesota or UMN database, is an excellent source of potential donors for our study on attributable risk of living kidney donation. To find potential controls, we decided to use a large epidemiologic cohort study known as the Rochester Epidemiology Project, or REP. This cohort study is a collaboration of clinics, hospitals, and other medical facilities in Minnesota and Wisconsin. But most of our work is going to focus on patient encounters in Olmsted County, which is home to the Mayo Clinic, as well as the surrounding 6 counties. Now, there are 2 main providers in Olmsted County, the Mayo Clinic and the Olmsted Medical Center, or OMC. And so this cohort study involves community members who have agreed to share their medical records for research. Data from the Mayo Clinic and OMC that's available in the rep date all the way back to the 1960s, which conveniently is approximately the same time that kidney donation began at the University of Minnesota. Diagnosis and procedure codes are available electronically going all the way back to 1966. Laboratory values, at least in electronic form, are a more recent phenomenon of the rep, but paper charts are available for chart abstraction. And so we're going to use the rep in the design phase of our study in order to identify potential controls to then go and collect data on. So as I mentioned, the rep will be used to identify potential controls in our study. That is, it's being used in the design phase of our research study. We're going to match UMN donors to 4 participants in the rep, which I'll refer to as potential controls. These potential controls will be exact matched on race and gender and must be within 5 years of age. They must have both 1 visit before and 1 visit after the index date. That is the date of donation for the living kidney donor. Also, importantly, at the time of the index date, the rep controls or potential controls cannot have any diagnosis code, which is considered an always exclude condition for kidney transplantation. After these 4 potential controls are identified, they're going to go through more extensive screening using the charts. They'll be reviewed to ensure that there's not additional information in the chart which would have excluded the participant from being a living kidney donor at the index date. This overall process ensures that the controls are contemporaneous to donors and typically from the same geographic region, since the University of Minnesota program often drew donors from throughout the state of Minnesota. But of course, identifying both donors and controls using existing data comes with limitations. And these limitations need to be interrogated. And we need to understand what data is and is not included in the UMN database as well as the rep. In particular, for the controls, we only have data available from the Mayo System and the Olmsted Medical Center, or OMC. Patients who do not seek medical care or who are oftentimes relatively young and healthy and therefore do not seek care are simply not eligible to be considered controls in our study. Additionally, we have challenges where patients may seek care outside of the system of interest. Here are the Mayo System and OMC. And that information would not necessarily be recorded within the rep. For example, if a resident of Olmsted County had a heart attack while visiting a relative in another state, that may not be recorded within the charts in the Mayo System or in OMC. Common lab measurements, which would be used to screen potential living kidney donors for our potential controls, were not routinely recorded in an older era, or sometimes were just recorded as normal. Other lab measurements are not always commonly recorded among the young and healthy. For example, creatinine measures, which are used to assess kidney function, are not frequently recorded among young, healthy individuals. Even so-called healthy controls may have different distributions of covariates compared to the donors in the UMN database. And lastly, we do have some potential follow-up data in the UMN database as well as in the rep. But these are collected in 2 different sources and in 2 different manners. The UMN database is a survey-based data collection procedure, whereas the rep is about chart abstractions. And so as part of using existing and secondary data in pragmatic research, we need to think about how these limitations can be ameliorated in the design and analysis phase. And in particular, as part of this study, we are going to survey all potential controls and donors about their health history, both before and after the index date. As there are more than 4,500 donors in the UMN database, this is going to necessitate more than 20,000 surveys that are going to be filled out. Participants will initially be mailed the survey, but they'll also be followed up by phone if they do not respond to the mailed survey. The advantage of using a survey to assess participants' health is that we may learn some exclusionary conditions that occurred among potential controls prior to the index date. For example, that participant who had a heart attack while visiting a relative in another state, potentially prior to the index date. We might learn about that through a survey, and prior heart attacks would almost always exclude a participant from being a living kidney donor. Additionally, the advantage of this survey is that the data are going to be ascertained in the same way between donors and controls. Of course, such a strategy to ameliorate the limitations of existing data are not always available. This is not a cheap option and is only possible because this is a grant-funded study. Additionally, besides collecting survey data on the living kidney donors as well as the potential controls, we're also going to query the USRDS and National Death Index to ascertain the date of end-stage kidney disease and death dates, as we're going to augment our initial source of existing data with another source of secondary and existing data. This source of data will be ascertained in the same way between the donors and the potential controls as before. And because now we'll have multiple sources of data that are ascertained in the same way between donors and controls, this can help calibrate some of the outcome data that's available from the REP and the UMN database, which may have been differentially assessed and without calibration would lead to potential biases. Now, of course, anytime we take data from multiple sources, we're going to require a detailed data integration, and if data are collected from sensitive sources, a security plan. In the context of this study, we have data from multiple different sources. We have medical record data from the Mayo Clinic and Olmsted Medical Center that's housed in the REP. We have the University of Minnesota database about our living kidney donors. We have survey results, which we're going to generate as part of this study, as well as data from sensitive government registries. Each of these need to be housed consistent with their data use agreements. And in particular, each institution, due to privacy concerns, needs to query USRDS and NDI separately. And so we've spent a lot of time thinking about how to create an essential database, how data will be transferred, in this case, from the Mayo Clinic in a de-identified way to the University of Minnesota, so that we can have a central study database that allows for analysis of results. Getting back to how we're going to ameliorate some of the limitations in our study, it's important to acknowledge that not only do we need a data integration plan, but anytime we take data from multiple different sources, we also need a statistical integration plan as well. We have multiple data sources here, some of which give information about the same outcome. And of course, they may give conflicting data about the presence or absence of a particular condition. For example, patients' self-reported health history, cardiovascular health history, might be different than what appears in the medical charts, and it might be different than what's available within national registries. This could be differences in whether or not the disease is even present or the date of first occurrence. The follow-up will be different between these studies. The REP primarily has data on participants so long as they maintain residence within Olmsted County or within one of the surrounding counties. And patients are generally censored at the time of last visit. The UMN database has data available up until patients' last response to those every 3-year surveys. This could be quite different than the data that's available when patients and participants complete the survey that we're mailing as part of this study. Some sources of data will also be missing. So for example, not all participants will return the survey that we're mailing as part of this study. And for example, even national registries, which are often quite comprehensive, those will also have missing data, and certain participants who have characteristics may or may not be represented within these national registries. And so an active ongoing goal of this study is to determine the best statistical methods in order to combine data from multiple sources. Lastly, I want to discuss about how we can use advanced statistical methods to ameliorate some of the concerns regarding confounding. For example, one of our plans is that once we've identified subjects in the rep as being healthy enough for donation, we will likely rematch and or adjust for common comorbidities and risk factors of cardiovascular disease and end-stage kidney disease, which may be imbalanced between the healthy controls as well as the living kidney donors. Now, one challenge of this study is that many controls will not have lab values available, particularly those who are older and have data going back several decades. We plan to consider several sensitivity analysis, where sometimes we assume that these values are normal. And in some analyses, we exclude participants who don't have common laboratory measures, which are important as part of assessing whether a participant may have been healthy enough for donation. For example, we might exclude in a sensitivity analysis someone who did not have a creatinine measure or other measure of kidney function. Lastly, I want to emphasize that many perceived weaknesses of existing and secondary data really ought to be reframed as strengths for pragmatic research. Yes, data are irregularly and inconsistently collected as part of many existing and secondary data registries. This is often a data management challenge, but it also ensures that data on outcomes are clinically meaningful and that we don't record a whole bunch of outcomes for which patients never sought care and that are not meaningful to the patient. Yes, as part of existing and secondary data, there are often fewer data quality checks, which often leads to more measurement error and incorrectly assessed outcomes, whether the presence of them or their timing. But as part of using existing and secondary data, we often get data that are actually available to patients and physicians, the exact data that they're using to make decisions about their healthcare. And shouldn't our research be about giving patients and clinicians information that they can use? Other limitations can often be viewed as an exchange or a transaction. For example, in exchange for the challenge of integrating multiple sources of data, we often have a more complete understanding of health outcomes in a cohort that doesn't include any selection bias. So, for example, in this study, we were able to get all donors at the University of Minnesota, not just those that agreed to be part of an onerous RCT or prospective epidemiologic cohort study. I want to conclude by posing some thought questions that I think should guide us throughout this conference. And I'd be interested to hear either in the chat box or through Twitter, what are some of your answers to these questions? So for example, in your research, what are some key barriers to using existing and secondary data, and how can they become overcome? How can the limitations of existing and secondary data be rephrased as relative strengths, perhaps to respond to a government funder? And lastly, one thing that I'm particularly curious as a statistician and methodologist is what can we do to improve the suite of available methods to make using existing and secondary data more palatable? Are there certain tools that you feel like you're missing that I could help you with? And so I want to conclude by reiterating the points that I made earlier. Existing and secondary data can and should be used at many points in the life cycle of pragmatic research. Any source of data should be interrogated for not only what it captures, but for what it does not. Limitations of existing and secondary data should be ameliorated in the design and analysis phase of a study. Using existing and secondary data often required a detailed data integration and security plan. And lastly, let's think of weaknesses of existing and secondary data as potential strengths, particularly for pragmatic research. I want to thank you for your attention. These are all various ways of getting in contact with me. And I look forward to hearing some of your comments and questions in the chat box, on Twitter, or through other forums at this conference. Thank you for your attention.
Well, that was fantastic. Thank you so much, Dr. Vock, and thanks for the great resources that everyone has shared in chat. We have about a 15-minute break now, and with the next session, we have some really fantastic breakout sessions on managing real-world data that follow from what Dr. Vock presented this morning. And then we do also still have track 1, which focuses on dissemination implementation science and has a great session on patient-reported outcomes measures if you're interested in exploring that in more detail. So we'll see you in your breakout rooms in about 15 minutes, and I hope you enjoy the rest of the day. Thank you.